Hi everyone, welcome to Airwaves, the Safe Airway Society live stream program. Tonight we're going back to basics, looking at arguably the most underestimated, difficult and important of the three upper airway lifelines. Face mask ventilation is often our last line of defence before neck rescue, and on an everyday basis it's the technique that buys us time to calmly optimise success with a more definitive airway by maintaining oxygen delivery between attempts at supraglottic airway and tracheal intubation. I'm Nick Chrimes, and today I'm joined by anaesthetist Pierre Bradley and intensivist and anaesthetist Joe Simpson as we discuss the dark art of face mask ventilation. Hi everyone. To start, it wouldn't be an airway program if I didn't start off with a plan B. If we have technical issues, I will... If you go to the, for example, if the stream actually drops out, it might take 10 minutes or so for us to get up and running again. If that happens, I don't know that it goes back to the same link, but if you go to the Safe Airway Society Twitter account @SafeAirway, and they will tweet out a new link if that becomes necessary. Hopefully it won't. You can follow Safe Airway Society on Twitter while you're there. Thanks you also to our sponsors Fisher & Paykel, who've provided financing for this episode. I'd just like to make it clear that myself, Pierre and Joe do not receive any funding, and the views we express will all be our own today. We want this to be an interactive session, so if you're watching on YouTube, you can submit comments there and we will put them to the panel in real time and have a discussion. Afterwards, you can also discuss on Twitter using the hashtag AirwaysFMV. I'd just like to also encourage you to join the Safe Airway Society. We're a registered charity. We're doing a lot of educational work, and membership is a large part of our income for that. So if you go to the Safe Airway Society website, safeairwaysociety.org, you can become a member, and it gives you a substantial discount on all our events. Speaking of events, I'd just like to promote our Airway Workshop Roadshow. We've just a couple of weeks ago had a big successful workshop in Melbourne, and our next stop is Perth. That's on the 28th of October. Oh, no, it's not that. Sorry, I've given you the wrong one. Just a minute. I'm building to that. That's the annual meeting. The Perth workshop is on the 9th of September at Fiona Stanley Hospital in Perth. We're running a workshop there, and following that up with another one in New Zealand at Auckland on the 14th of October. And then finishing off the year with our big annual meeting on the 28th of October at Royal North Shore Hospital. This is a full day meeting. The morning will be plenary sessions with some great speakers, including Tim Cook. They're going to be interactive sessions, just panel discussions with audience engagement, not just didactic talks. And then the afternoon is a series of workshops, including simulation. You get a choice from a whole range of workshops. All of those included in the registration price. And for non-members, that non-member registration price includes an annual membership to the Safe Airway Society. So because of the included workshops in the registration package and the high instructor participant ratio, we have very limited numbers, and this will sell out, so don't miss out. Okay, let's get on with the show. My first guest is Pierre Bradley. He is an anaesthetist at the Alfred Hospital in Melbourne. He's a past chair of the ANZCA ASA New Zealand SA Tripartite Airway Management Special Interest Group, for want of a longer name. And he's an author of this BJA Education article on face mask ventilation, which is really, really excellent. We'll be talking about a lot of what's in there today. So please welcome Pierre Bradley. Hi, Pierre. How are you?
Hello. I'm good, thank you, Nick. And thank you for inviting me to talk on probably my favourite topic of airway management.
Excellent. We're simple folk, Pierre. We're simple folk. Also with us, we've got Joe Simpson. She's an intensivist and anaesthetist at Eastern Health in Victoria and is supervisor and training there at Eastern Health. Welcome, Joe.
Hi everybody. Thanks for the invite. Good
to have you. Shall we get right into it? I was saying to you beforehand, I really like this topic because people love to go on and on about neck rescue and high frequency jet ventilation, and they're all great things, but face mask ventilation is the thing. This is the bread and butter. This is the stuff that every day is keeping us out of trouble, and I think this is prevention is where it's at. This is the stuff that actually makes a big difference on a day-to-day basis. Okay, so let's get into it then. Sorry, I'm running a lot of screens here. I have very bad at multitasking. Okay, let's talk about the significance of face mask ventilation. Pierre, in your BJ Education article, you describe face mask ventilation as arguably the most essential skill in airway management. Why is it so important?
Well, first of all, you've already started off by saying it's the bread and butter of basically all airway management. We've all learned how to, often it's neglected, but we've all learned how to open up the airway. It's a simple procedural skill that can be taught well and using basic equipment, and the opportunity to do harm, such as an esophageal intubation, is not there. It can function on multiple levels, either as a primary technique for anesthesia, which obviously gas inductions I quite like, providing supplemental oxygenation.
You're being a small number there, Pierre.
Sometimes you have to do it. I suspect the pediatric anaesthetists do a lot more than us, but it still has relevance in certain situations. It assists with oxygenation, and as you've already mentioned, it serves as a rescue technique or lifeline, which avoids or potentially avoids complications and leading on to neck rescue. Taking from our own situation, when you get a laryngospasm, when an LMA is in, you quite often take out the LMA and go to bag masking or deepening things. It's readily available, but it's really is neglected. I generally think the problem is it's easy to get the basics, but to master it actually requires a great deal of experience. And I think in some ways that's actually been reduced over time because of advances in airway management. It's a lot easier now with supraglottic airways.
I'm going to come back to this issue in a moment, Pierre, because I think that's another interesting discussion. I think, as I was saying in the opening, it buys time for other airways to be established. So in a lot of ways, it has a human factors impact as well. When face mask ventilation fails, then sure, you can go on having your repeated attempts at supraglottic or intubation. But if you haven't got face mask to restore oxygen delivery in between and the patient desaturates, you're under a lot more pressure, and probably everything suffers from that time, both through time pressure, your thinking, your motor skills deteriorate. So it really is part of that, what Tim Cook has described as composite failure. Once one of the lifelines becomes compromised, the livelihood of the others are failing as well. And that happens for anatomical reasons, but I also think it happens for that human factors reason as well, that once you lose the ability to deliver oxygen, the pressure on you to do everything else means that you probably don't do it quite as well. Joe, yeah. What are your thoughts on why face mask? Why have you chosen to spend your Monday evening talking about face mask ventilation?
Well, I kind of echo what Pierre said, really. I mean, when I started anaesthetic training, I wasn't allowed to use any other device until I could master face mask ventilation. And for me, it's accessible to most people. So when you've got an arrest on the wards, the first thing that people do is they've got the bag mask and they're trying to ventilate. So you can actually train a lot more people to manage an airway. And then it's just that kind of security to know that I can face mask ventilate a patient before I then move on to harder techniques, which may end up failing. And if you fail or have a difficult face mask ventilation, then you're likely, or there's a potential to have a difficult intubation afterwards. So it puts you in that frame of mind of saying, okay, well, this isn't working already. We need to start thinking about next plan. So it gives you a bit more time to prepare for those difficult intubations later on.
So this caused a bit of controversy on Twitter when we raised the idea that it was potentially more difficult to learn than laryngoscopy. I don't want to spend a lot of time on it, but do you think it is more difficult?
I think it's less forgiving. I think it's probably less forgiving because you need to, if you haven't got a good seal and you haven't got patency, then there's not very many other adjuncts that you can use to really try and improve it. So I think in that respect, it can be difficult. Sorry, Pierre, I interrupted you.
No, you should go first. I actually think it's the technique that you can do the least harm with. I think there's actually, it is harder. You said we'll come back to supraglottics, we'll come back to that. But also at the same time, we're actually doing less of it. The old-fashioned apprenticeship model has effectively died. And because we have other techniques, people don't know what they don't know. So whilst it seems superficially easy, the techniques that are there have been forgotten to time, or they come out and it's almost like a pearl of wisdom. And you go, well, I'm old. My guys taught me that in the past. So I don't think of it as anything new. But sometimes with the apprenticeship models, and you're only seeing someone for a short period of time, you don't get the opportunity to see their progression. So therefore, they come away with a limited or understanding of what to achieve. And then eventually they become the consultant without actually picking up those finer points.
I think one of the hard things about face mask ventilation is it lacks the defined endpoint of intubation or placing a supraglottic airway. Once you succeed with those things, you have a fairly stable airway. But face mask ventilation has this ongoing dynamic component that you can succeed in it, but then there's this ongoing thing you can lose it again.
But that gives you actually a lot of feedback. Having that feedback gives you a lot of information about the patient while you're doing it. So it's kind of good to have that tactile.
So let's okay, Pierre, you're clearly poised to say something brilliant.
Yeah. It's going to be brilliant. I agree with you, but I would say there is an objective measure now, which I think you're going to address later anyway.
Yeah, I'm not saying there's not a measure of success, but once you succeed with intubation and supraglottic airway, they're pretty much done. You can succeed with face mask, but lose it again. So we'll talk about that again. Let's talk about evaluating the risk of face mask ventilation. Pierre, I think in your article, you talk about the incidence being of difficult face mask ventilation being 1 in 100 and impossible being 1 in 200.
Depending on what articles you're reading, depends on the thing. But in simple terms, you say it's somewhere between 1 to 2% of difficult face mask intubation and about 1 in 1,000 of impossible, depending on the articles. I can give you a range, but that's realistically the magnitudes.
Yeah. So I just want to highlight this document, another of your body of work, which is probably the most comprehensive publication on airway evaluation I think that's out there, and I think gets very little recognition.
I would also say it is missing something you're going to address a bit later on grading systems, but it does cover most things.
Yeah, we'll talk about that in a moment. But it's very detailed at going through all the literature on what are the things that identify risk. I'm very big on distinguishing. I'm not a big fan of the idea of predicting difficult airways or predicting difficult face mask ventilation. My take would be we don't have the tools to predict it. If you predict it, you say it's going to happen. I think the point of airway evaluation is to identify at-risk face mask supraglottic airway intubation. I know there's all these things, and we often integrate all these things to get a picture of whether they're at risk. But Joe, I was going to start with you and just ask you, in terms of red flags, by which I mean, what are the things that you look at that you think if they've got that, then whatever else, even that on its own says I'm worried. What are the things that concern you as red flags when looking at potentially challenging face mask ventilation?
Yeah, so some of it will depend on the situation that I'm in. So is it a critically ill patient that's got respiratory failure that's already compromised? Because that will be an alarm flag to me to start off with. And then looking at the patient themselves. So how am I going to get that seal? Because I've only got little hands. So anybody with a big head, big cannonball head, anybody with, obstructive sleep apnea, with big tongues, anything where I'm going to have difficulty being able to do two manoeuvres at the same time is going to highlight to me that that this is going to be difficult. So I'd say those would be my red flags. But yeah, take it into the, in consideration with the situation that we're in. I might be slightly more wary if I know that my other parts of my kind of system that I use in my head are at risk. So that would be, the sick patients.
So I think that's really important, and particularly from your context in intensive care and other out of theatre contexts, is that we're all thinking of airway risk assessment in much broader terms now. It's not just about anatomy; it's about patient, team, and situation factors. And even under the patient factors, it's not just anatomy; it's physiology and other things. Pierre, what are your red flags? What are the things that make you?
Well, first of all, it's time, location, and who's around me. That makes so when I go to the emergency department, I'm a little bit more anxious because it's not my usual team. If I have to go to the wards, I usually know no one there, and they're resource limited. So the ability to have help makes a degree of anxiety depending on the situation. But going back to specific components, I think there's a little bit of an art to the science. I think you do have the physiology, which Joe's been talking about the time you've got before things deteriorate and how much you can optimize things. But in specific things, you've got the science side of things, which has really come about from the work from the Michigan guys, Lundstrom and Langeron, which basically say, be worried about, yeah, this is going to sound bad, be worried about fat blokes with beards. They're usually hiding a chin, and I generally tell people don't trust them. So that's really not, I should have had a shave before this. But the other things I look at particularly are the jaw protrusion, because it again goes on to sort of the two curve theory. How can you create space? There is a feel to the jaw when you actually feel it, how tense you are under. And I think that's what you mean by the round head. I've also got small hands. There's a feel under there. So if it's tense and you can't compress the submental region, you're probably not going to have much compression on the inside and being able to.
Tell me that your airway evaluation involves touching the patient, Pierre.
It does.
This is groundbreaking. You are awesome. Good to hear.
I am. Yeah. Jaw protrusion is an alarm bell for me. And submental feel.
This test, you mean?
Bring forward. But I'm also actually assuming the position I'd be standing in theatre and usually feeling the person's jaw and asking them to protrude at the same time. So I find with what I'm doing, I get a haptic feedback on my hands, and that gets a feel for what I'm doing. But it is based on the science, and then it's also further enhanced by my own experience about where I've had problems in the past and not. And beards, awful.
We're doing a lot of apneic oxygenation by various techniques, but it all started in ED with just nasal cannula. Do you think things like nasal cannula or nasogastrics, when they're in situ, do you think they impede face mask ventilation, or do the modern masks now sort of wrap around them pretty easily?
I think the modern masks wrap around them pretty easy. The seal generally, in my situation, is usually either saliva or vomit or blood. That when I'm going down somewhere else. In the elective situation, it's usually not an issue.
Yeah. Joe, are you doing a lot of apneic oxygenation in your patients in intensive care?
Sometimes, yeah. And it can get in the way. I mean, some of the NG tubes really can get in the way. So I have to really press the mask right in.
Would you ever take them out if you were worried, or?
No, because I tend to aspirate the stomach first and then try and pre-oxygenate. I try and keep them in.
Okay, I want to one last thing on evaluation. Well, this is not really about evaluation, but if you're worried, I just want to comprehensively debunk, because this came up for me in the last couple of weeks. Test ventilating before giving neuromuscular blocking agents. I thought this was finished, but someone raised it last week. Is there any reason to do it? Are we way past this now? And I'll just say I've got a whole lot of articles here that all debunk it. So I would have thought it was pretty much over and done with. But Pierre,
I thought it was 20 years ago. I think last millennium, I think it was debunked. There was a debate round about 98 from recollection about this very thing. Test ventilation's just bullshit.
Joe, you on board with that?
Yeah, I'm on board with that. When I first started anaesthetic training, it was still a thing to test ventilate. But, when you actually ventilate with muscle relaxant on board, it's so much easier. So I don't know why you'd even bother trying without it.
I think it's one of those things that superficially seems safe. In fact, I love one of those. I think it's the second article there. Could safe practice be compromising safe practice? I think Steve Yentis always has great titles to his articles. But I think, I think it's one of those things that superficially seems like it would be safe, but if you think through it, it actually doesn't achieve anything except make everything more difficult and more likely to fail. Okay, let's keep moving. I want to talk next about the issue of technique. So Pierre, you've spent a lot of time on technique. I think about optimizations for all the airway things at two levels. There are proactive optimizations that we do before we encounter a problem, and there are reactive optimizations that we do in response to a problem. Pierre, in your opinion, what are the core baseline elements of face mask ventilation that should be routinely incorporated every time?
Your position, patient position, and seal. It's three simple terms.
Let's talk through some of this. I've got some images and videos from your article here, so let's go through this and feel free to jump in also if you've got anything to say, Joe. So you talk about, I thought this was interesting, was operator stance. I've never thought about this at all. Joe, is this something have you thought about?
I've thought about it since it makes sense, because if you've got a slight lean back, you're not then leaning on the patient's face and just squishing everything down. So, it gives you a bit of lift. I think it's a good idea.
I really like the phrase in the article, Pierre. You talk about pulling the face up into the mask, not pushing the mask down to the face. I think that's really crucial.
Yeah. That's part of the seal. So if I'm doing it, if you're big and strong and massive hands and great guns, you're going to do the face off. Now, for the rest of us, you need technique, and technique basically involves getting the right position so you can minimize the amount of work you do. And I actually learned this from a rock climber lady over in New Zealand, Isabel Ross, many moons ago, and she just got the position right, so she was able to minimize her workload and actually get her position right, so she optimizes the forces. And I've got two schools of thought when I'm watching someone. So the schools of thought are, if you've got your body position open and you've got your hand on the face mask and you've got a big open view, so you can see, on this case, you can see everything's going on around you, and a slight lean back takes the pressure off. And as things get worse, if you've not got the correct position, you're going to go what I call the oh shit position, which is you just suddenly pull your hands towards you and you bend down and you're just focusing on the face, and you lose the objectivity of what's going on around you. So I think the positions actually of you is absolutely crucial relative to the patient. And I appreciate in other environments outside theatre, you may have to compromise those situations, but that's one crucial element. The second part is the actual patient's position, and this also depends if you've got to worry about neck stability, and that says it all. You want to achieve something like that, and then that's combined.
So I just want to point out, because I think this, and I apologise to whoever's picture this is, because this is off Twitter from a few years ago, and I don't know who to credit it to, but I think it makes a really important point with the ramping and the torso elevation we do now. I think you see a lot of this, that first picture on the left there. People will look at that and say, "Oh, ear above sternal notch." It is vertically, but if you flatten the patient out again, you can see that they're actually just hyperextended. They're not actually in that flextension position at all in that picture. They're just hyperextended. And so I think one of the things I sort of like to emphasize is when you're doing that flextension, you're getting the ear above the sternal notch in the coronal plane of the patient, not just vertically in the room. So I think that the ramping often disguises, and you've got to look at the patient and say, are they ahead? Is there ear ahead of sternal, in front of sternal notch in the coronal plane? Yeah. I want to show a picture, a little video here I've got from you, Pierre, about face mask application, and then we'll talk a little bit about grip. It's still starting.
Application of the mask is done by optimising the position prior, pulling the submental region up, then placing the mask on. For a one-handed grip, you are putting your thumb over the superior aspect, your index finger over the inferior aspect of the mask, and going over to the other side. Your middle finger is on the submental part of the mandible, and the other fingers clamp on, going back towards the angle of the mandible, depending on the size of your hand.
So, sorry, go, Pierre.
So I was going to say, the important part of that is actually positioning the face before you apply the mask on. And one of the other, this is a little thing, is when you saw my hands, the angle piece was resting on my palm. And the reason I said go over, so you can do lateral movements and you can do pronation and supination movements.
Right.
Sorry, Carrie.
I'll show you that. I'll show it in a minute, because I think so. It comes into what I was leading into next is the grip. So you showed there in the video the sort of classic claw C grip there. We've also talked about the vice grip, which I might show another video, because you demonstrate quite nicely how to put this on. I'm going to push my luck and try to play another video. Hang on.
The first line grip that most people should use is fingers behind the angle of the jaw, causing a clamp or vice grip. So angles pulling it forward. Have the mask put on by your assistant. And then you pulling your fingers up, and your femur eminence is down, pushing down, and you get your assistant to inflate and deflate. So that is the two-handed vice grip. My assistant in that case was doing the videoing. Thanks.
I think the vice grip was actually shown to me by a medical student. I was doing a BLS workshop and showing them how to hold on a face mask, and they said, "Oh, I've been told to hold it on like this." And I've certainly have situations where I haven't been able to mask ventilate at all, and a vice grip has gotten me out of hot water. Is this something you use, Joe?
Yeah, I use it when it's come, like you do, to get yourself out of hot water. But I do teach it for the people that aren't used to bag mask ventilating as a first start, because when I first started, my hands just used to be stuck in like claw positions, because they tire, the muscles in your hand tire really quickly. So if you're not managing airways regularly, then this is the technique that I would teach people, because it means you can ventilate somebody for potentially a prolonged period of time until somebody else comes to help you out. And you know you're going to get a good seal.
So in addition to the increased mechanical advantage it gives you, it's just a rest because it's different muscles to do it. I agree, and I think the other thing is, you know, you can do that, and you can actually lift if the patient's poorly positioned. You can actually lift their whole head into a sniffing position, so you can get some real force there. Because rather than doing jaw thrust just with your pinky, you've got all the fingers there. I think again, Pierre, you talked about the patient position. I think getting vice grip to work, you need the patient low enough. If the patient gets too high, you can't rotate your wrists enough to get that sort of downward pointing of your fingers.
Yeah, which is every CPR bed during cardiac arrest. They're always really low.
I agree with you all. I think this is the basic grip everyone should be taught. And I think this is effectively what I would consider the novice grip and the rescue grip in most situations. Though to be honest, my preferred rescue grip is actually the two-handed combined, sort of what I would call the vice/CE. So you've got the benefits of having the old classic grip and having a vice grip.
So that's with one hand doing classic and the other one doing vice. And I think you described that as the sort of the hinge and the lock.
Yes, yeah, door and hinge. But I think that's an advanced technique. I personally prefer it to the vice, but as I say, I do appreciate why I'm doing it. But I think without a doubt, this should be the first line grip, full stop.
So let's talk about that, because I think, the other thing about what I've talked about, sort of whether optimizations are proactive or reactive. I think the other thing that's interesting about face mask ventilation is that almost all the optimizations are incremental rather than alternative, by which I mean you can superimpose them all on top of one another. Supraglottic airway is very different. A lot of the optimizations for that are you're going to use a different type or a different size, or you're going to put it in backwards, and you can't do all those things at once. But other than changing the size of the mask, most of the other things that you do, you can superimpose. So it's possible to have a best effort to just blow your load all at once and do everything. How much, for want of a less appealing metaphor, how much do we need to optimize? You know, we talk a lot about first pass success with intubation. Is first attempt success with face mask ventilation equally important?
Yes, I reckon it's a really good comparison to make. And, you know, it's obviously dependent on the clinical situation. I think if you've made some assessments and you think the patient might be, difficult face mask ventilation, then why waste your time trying different positions with your hands? Why don't you just get the oropharyngeal airway, do the vice grip right from the start, especially if patients are physiologically unwell, so they've got no respiratory reserve. It's going to be difficult to oxygenate them. And I think this is more pertinent in people that don't have airway experience, so they're first responders, because they may not have the other skills to then bail themselves out if they can't mask ventilate. So I think you want to be able to know you can ventilate with the mask before you try and attempt an intubation. So I think if you feel that it's going to be difficult, I don't see why not. I think it's a good idea.
Pierre, you're looking very thoughtful there. Go on.
No, I agree with that. Yeah. So I think there's two schools of thought. There's one school of thought that is you put the oropharyngeal airway in straight away, and the other is not. And in our circles, it could be the cardiac anaesthetist would say, put all laparoscopic based anaesthetist would say, I'll put it in straight away. I'm of the other school of thought that I think it damages teeth, distracts from actually learning how to do the skill properly and then using it as an adjunct. Both methods, both schools of thought have pros and cons to it. I think generally this is again a personal view. Banging in on an oropharyngeal airway straight away can sometimes mask poor technique, and you don't get the full benefit of the oropharyngeal airway when you really need it. Yeah. Thanks.
Joe, rebuttal?
Yeah, so I think you're describing different situations really, with different skill mix. So I think what you're saying is true. If I was doing a simple case where I wasn't concerned, then I wouldn't always jump straight to an oropharyngeal airway. But if I was, somebody that's just running to an arrest who doesn't deal with airways regularly, I think I'd want to try and do everything I could straight up. So I think it depends on the situation and your expertise.
Yeah. And I think that's the opposite thing, was expertise. So it's all down to training.
It's also a bit, and we'll talk about devices a bit later, but it also depends what you're using with. If you're using one hand, you're with a flow inflating bag, a soft bag that you get a lot of tactile feedback. There's value in a one-handed approach to get that feedback from the other hand. But if you're using a BVM, a self-inflating bag, where you don't get a lot of feedback, then you're probably better off just having both on the mask, and also that you're probably also in the context where you've got sicker patients and the occasional airway manager, so that a lot of those things go together. So maybe also context goes into how you start in terms of grip.
Mm.
Let's talk about one other thing.
I'll just say on the comments,
Yep.
Matthew, yes. Airway manoeuvre first, seal second. Yes. And it is a little bit of like a chin lift to maintain the position. Sorry, Nick.
No, that's good, because what I was just about to say, let's go and see if there are any questions, and just remind you to let me get rid of that. And
the first line grip.
Oops. See, this is why I didn't want to play the videos, because once they play, I can't stop them.
Causing a clavicle vice grip. So now Ingle's pulling it forward. Have a massive.
He's hard to shut up, Pierre. Okay, so the can't even remember what I was going to talk about. Oh, yeah, just to look at the comments here. What have we got here? So nasal airway.
Yes.
Nasotracheal airway. Is that supposed to be nasopharyngeal airway?
Pharyngeal.
Yeah. What are your thoughts on nasal? People are very polarized on nasal airways.
Joe, do you want to go first, or do you want me?
I don't use them very often.
So I have to say, I am a neuroanaesthetist. So quite often there's either trauma, which makes me want to avoid it. I do use it, and I think it's good, but I think the issues are, you have to put it into context. Are you worried about bleeding or not? Yes, I do use them, and yes, I do put 2 nasopharyngeals and an oropharyngeal airway in when I'm really up shit creek.
I often say, if I was going to die from not getting an airway, I would rather die with an oropharyngeal airway and 2 nasopharyngeal airways in. But I tend to use them more in a situation where either I'm anticipating problems, or before I wake a patient, so I can put them in a controlled way, so you're less likely to get bleeding. I think if you're panicking and rushing to get them in, they can cause problems. But again,
I think the bleeding's a really valid point, because if you're struggling and then you're putting in a nasopharyngeal airway, and it's going to make life very difficult when you're going to try and get an ET tube in, or the next step after that.
It sort of comes down to the sequence of things you're doing as well, then, because you can. What am I saying? If you've had all your attempts at intubation, then you've got nothing to lose. So as a last resort, before you're going to move to neck rescue, it's probably worth doing, but you might sort of defer it rather than do it early on. I don't think there's any other questions there. So let's move on. I'm going to talk quickly. This is from our sponsors now about the Optiflow, not the Optiflow switch from Fisher and Paykel. So we've got a quick video from Anil Patel. Again, just reinforcing, none of us here are getting any sponsorship from Fisher and Paykel. But this is just Anil Patel explaining how Optiflow switch works, and it's relevant to the discussion we were having before about getting a seal with around nasal prongs and nasogastric tubes.
Hello, my name's Anil Patel. I'm an anaesthetist that works in London. I wanted to tell you a little bit about the Optiflow switch device. So now this device, the Optiflow switch, has been developed surprisingly for a piece of tubing that compresses. One might think that it's a very straightforward process. It actually turns out to be a really complex engineering challenge. And so the elements of this now are that we have a compressible piece of tubing that is independent of whatever the flow rate is. So whenever we do face mask ventilation over this device, it not only compresses at just the right tension so that it allows us to undertake face mask ventilation, but it allows us to compress this irrespective of whatever the flow rate is. So whether the flow rate is 20 or 40 or 70, the force that's needed to compress it is exactly the same. Now, that actually in itself has involved a very significant engineering challenge, and that's evolved into this box here, which allows us, irrespective of the flow rate, to always flow divert at this point with exactly the same face mask pressure. So we would now induce anaesthesia, having pre-oxygenated the patient with nasal high flow. We would then check face mask ventilation and release. So that is a very brief description of the Optiflow switch.
Okay, so I think this is just my opinion. I actually had the opportunity to play with this clinically for the first time a few weeks ago, and I think it's a fantastic device. You know, it provides the safety from barotrauma of being able to put a seal on high flow. It improves face mask pre-oxygenation because it compensates for face part, whilst it doesn't contribute to getting face mask leaks like a nasal prongs or might potentially. If you do get a slight leak, the flow will kick in and sort of make up for that leak. So I think it improves the quality of your pre-oxygenation, and you get the efficacy of apneic oxygenation with a high flow and PEEP with it. I think it's a great thing. The only thing I would say about it, criticism of it, is it needs more distinctive packaging between the switch and the Thrive. They're exactly the same, and if you put the switch on a patient who's having sedation with high flow and they lean on it, they can actually switch off the oxygen flow. So I think they've created a great device for peri-intubation apneic oxygenation, but I think it's if you're going to create a device that allows the patient to inadvertently interrupt their oxygen delivery, I think it needs to be more clearly marked. That would be my only criticism of it. Have you got any thoughts on this? Not sponsored thoughts, just your own thoughts. They're mine.
I agree with you, Nick. I've given quite a lot of feedback to Fisher and Paykel on this device during the course of its development and beyond. I think it's a wonderful step forward for the intubation situation.
Beautiful.
Yeah, because the length of apneic time that you get as a result of it is really good. It really helps when it comes to difficult airways.
Yeah. Okay, they're our thoughts, and we'll move on now. I want to talk about training in face mask ventilation. Joe, the occasional intubator, I know you do anaesthetics as well, but sort of dedicated intensivists and emergency physicians typically are occasional intubators and are typically doing rapid sequence intubations. And that can limit their opportunities for skill acquisition with face mask ventilation. How can we maximize their opportunities to learn this skill that we've said is so important when it predominantly only comes up as a rescue technique rather than part of their routine practice?
Yeah, well, it's like surfing, isn't it? It's time in the water, so it's time with the airway.
I wouldn't know if anything was like surfing.
Well, Well, you just need to keep practicing it, don't you? So I think we have to have, good relationships with our anaesthetic colleagues. So there's time in theatre to be able to practice these techniques. Good, quick turnover cases where you can do some face mask ventilation before putting in the ET tube is going to really help. And then go through that process that Pierre was talking about escalating through the adjuncts and the different hand positions. So quick turnover theatre lists. I think, opportunities in ED like procedural sedation might give you some time to try some face mask ventilation. But yeah, I think the main thing is that we need to support our paramedic ED colleagues that may not be able to have that much time being able to face mask ventilate.
I think the other thing is just getting them to hold the face mask on for pre-oxygenation. I know there's a trend in the US now of pre-oxygenating hands-free and even here using high flow to pre-oxygenate. And I think you lose that opportunity, particularly if you've got capnography on while you're pre-oxygenating, to check that your capnography is working, but also get a measure of whether you've got a seal. And I think you can perfect part of your face mask seal technique just during pre-oxygenation. Pierre, I think
definitely.
Sorry, Joe. Go.
I was going to say, yeah, definitely, because when in ICU we have our capnography on our face mask for the pre-oxygenation phase. So yeah, that's a very good point to be able to do some hands-on as you're pre-oxygenating them.
But I've seen in some contexts for urgent intubations that the capnography is very much seen as a confirm where the tube is device rather than confirm that you're ventilating by any technique you put in. And so it gets connected up, ready to go when the tube goes in. But if the tube doesn't go in and they revert to rescue face mask, they then don't have any feedback on whether it's working. And then, as we'll talk about in a moment, they've got the added problems that they're often using a BVM. Pierre, you're about to say something, but I'm going to ask you something else, and then you can do both.
Okay, I'm coming back to education. Yep.
I think this is just where I wanted to come back to what we were saying before about supraglottic airways. I think the other thing where we're losing opportunities here is I often see our trainees when they're struggling with face mask ventilation and they'll ask for an oropharyngeal airway, or they'll start escalating, and the senior says, just stick the supraglottic airway in, or just intubate now. And yeah. I'm the opposite. I say, no, get face mask. Embed at your brain stem the sequence of escalations to establish face mask ventilation.
I can only agree.
Yep.
It's Sean's week.
How do we stop this happening though? Because I think is it just me, or is it endemic everywhere? This sort of
we should be doing some lists just with face mask ventilation. Small lists, 15, 20-minute cases. I used to do it just face mask and SIVO.
Yeah, it's harder in some ways to do now because we've lost the apprenticeship model, and you've got a trainee who has 27 different masters, but no person actually seeing the depth of that experience. That's part of the problem. But I agree, Joe. It should be, you should have a go, do it rather than jumping straight to an LMA. And the LMA has been a great advance, but it has consequences. Can I come back to education now?
Yeah.
Education. So I take part in the Lawn Peter pub in the medical tent, not so much the swim. We have a great interaction with our paramedic colleagues there because we effectively run a field base, and they provide resources and oversight for us. And we take any opportunity to teach. So we actually run a training session on face mask ventilation there as an impromptu, and as well as getting them through the Alfred at times. So impromptu teaching wherever you can. And the second thing, which may be controversial to hospital managers, is that what I actually believe is anaesthetists should be rostered to the emergency department and the bigger ones for a session where they can take the opportunity to impart their knowledge, and vice versa. Senior consultants from ED should be rostered once a month into the anaesthetic to run a list with support. So they develop airway skills or not develop, maintain their airway skills. And at the same time, it actually enhances collegiality. So when you go downstairs, you've got people you know. And at the same time, yeah.
Yeah, again, absolutely agree. We're at Monash now, establishing airway leads from ED and ICU as in addition to the ANSCA program, just informally getting airway leads. So we've got some formal sort of network to communicate. And we've been running. It did stop during COVID. And we're trying to restart it again, but we were running a program of getting the emergency physicians and intensivists to come up to theatre, and I would chaperone them around. And rather than putting them in a list, which unless you get the right list can be problematic, because you know we might do a neuro case where they get to do one intubation during seagulls for the rest of the day. But I would just take them around and we would grab every intubation. Sorry.
That's beautiful. As a neuro anaesthetist, as long as it's nice level tramline seagulls, you made my day.
We actually chaperone them around and grab every intubation that we could in the afternoon, as well as some face masks. Really, every episode of airway management, and that was great for them because they would get sort of 2 years worth of airway management in an afternoon, all back to back, and then with the consolidation of being able to sort of talk through things. And between dead times, rather than sit there doing the anaesthetic, we would take them and do skills workshops and things, and that worked really, really well. And the other thing I noticed was exactly what you said, Pierre, is it was an opportunity to talk to our colleagues in intensive care and ED in a situation that isn't running down to manage an airway where things can get tense, but it just meant when you go down you say, oh hi, and you've met people before, there was an existing sort of relationship with them, and I think that's really useful as well. Sorry?
So I think certainly in our hospital we've got trauma calls. Having an anaesthetist down there full time is potentially beneficial because we can impart some skills and we also pick up skills.
Yeah, it's definitely a two-way street. I mean, apneic oxygenation is one. The emergency physicians were doing that for years before we got onto it. Let's move on to devices for face mask ventilation. So we've mentioned a bit about the Mapleson and the flow inflating bag. We've mentioned the self-inflating bag. There are people who are advocating using a mechanical ventilator now. Pierre, what do you think is the best device to use to ventilate via a face mask?
I think that's a very loaded question. But there's what I think the best device is, or it depends on the environment. If you were to ask me what should be the device that's readily available for everyone, I actually think the self-inflating bag, and the reason for that is it doesn't require a gas flow. What I consider the best device for actually ventilating a patient is a flow bag, because you get the tactile feedback. And I think you've got a lovely video of that, which basically shows you can work out whether it's patency or seal is a problem.
I'll just show. I made a little video here. Again, I'm struggling with the videos, but we'll see how this goes. No. Oh, there we go. So this is just on the bed, so you can see that when the mask is obstructed, you get a tense bag. But if you've got any leak, the bag just collapses, and so you get a very good indication straight away of whether your problem is obstruction or is patency or seal. And I think that's really important because it allows you to target your optimizations to the problem you're having. Now, people might say, oh, but if I've got a leak, I'll know because I'll feel a leak. But I think the reality is you always have a leak. If you've got an obstructed airway, the gas has got to go somewhere. So eventually it leaks. And I think particularly with a self-inflating bag, you don't have a feel for how much pressure you're generating. You just think you're getting a leak. But you can get a leak that's what I call you can have a primary leak because you haven't got a good seal, or a secondary leak because you've got a decent seal, but you're so obstructed that you're overwhelming that seal because the gas has nowhere to go. So
in reality, I agree with you. I think we ought to be doing flow bags.
Yeah. You say that it doesn't need a gas supply, the self-inflating bag, but what circumstance outside of pre-hospital or transport, will you ever not have a gas supply?
Yeah, but I said for all occasions. It's I've been.
You're one of these universal airway guidelines guys.
No, I'm not. You won't see my name on it. You've got the learned people on it.
I think as well with the flow inflating bag is that it's good for education when you're learning to do face mask ventilation. I think you shouldn't be learning face mask ventilation with a self-inflating bag. I think you need to be learning it with the flow inflate. Even if it's not something that you're going to use again because there's only self-inflating bags. If you're going to learn, then the flow inflating bags are going to give you that tactile feedback that we were talking about and make you understand what it is that the problem is. So I think for education, definitely.
I'm going to go and say this is my opinion on this, and as you know, I like to go very softly with my opinions. I don't think there's any role for the self-inflating bag as a first-line device in critically care trained hands. Because I think you can't have ward staff trying to use PEEP valves and stuff. That's ridiculous. But as a first-line device outside of a transport or pre-hospital setting, I just don't think there's any role for it. And people say it's more difficult because they say I can't ventilate, the bag's collapsing. And my response is it's not more difficult, it's just honest. You didn't have a leak with the self-inflating bag, you just couldn't tell. Let's look at some comments here. I'll just pop this up. So Chad's just asked, paper comparing high flow and oxygen to face mask ventilation of 15 litres in obese patients. 18 minutes of apnea time. Panelists' thoughts. There's also been just a bit recently a Cochrane review in the last couple of weeks that's quite interesting about high flow. I don't know if either of you had a chance to look at that. Yeah, about apneic oxygenation.
It's I only wish I could get 18 minutes of apnea with my high flow in my patient cohort, but they seem to desaturate.
If you need 18 minutes of apnea, you should have a different plan.
Yeah.
Let's see. Talking about education, in my hands-on workshops, I have attendants hand bag each other. They can experience how it feels. I ask them to bend their heads forwards and backwards.
Frightened to ask what handbag means. Is it swiping someone?
So I actually think this is interesting. I get my registrars to often tell them they should go and put the circle system on them. There's a lot of resistance in them when you're spont venting for peroxygenation that I don't think you realise. Even in something with very light valves like a circle has a lot of resistance in it.
Yeah, it's like trying NIV, CPAP. If you ever tried that, it's the same thing. It's not very uncomfortable.
Well, there's more to this.
Yeah. Yes.
Yes is the answer to that.
Totally.
Okay.
Totally.
Now we need to wrap up because we're a bit over time already. Oh no, we're right on finishing time. Let me just see. The last thing we want to talk about is documenting face mask ventilation. Okay, so I find this is done badly. Often there's no documentation of face mask ventilation, or it's just written that it was easy. Joe, how should we be documenting face mask ventilation?
Well, we need a description of the situation, and so you've got some context with it. We want to know who's doing it, what the situation was, what adjuncts were used, one-handed, two-handed, and then what the outcome of that was. So, we've spoken about this before. Was there a big leak? Was it difficult? Was there chest rise and fall? And then, looking at your end tidal CO2 trace as well.
Pierre, what are your thoughts? I think we should be documenting this with the same rigor that we document intubation. What is the effort you put in? What is the outcome you got?
So certainly I've been helping promote the difficult airway alert letter, which Queensland been involved with that, and the Lim and Nielsen Concord classification is basically what I think is the gold standard now. And I would also argue that's actually what you should be using on education as well for seeing the CO2. You mentioned capnography. that tells me everything I need to know. Yeah,
I'm a big fan of this. I would dispute that it tells you everything you need to know. I think there's a whole lot of domains you could document for outcome, whether you had leaks, whether you got good tidal volumes, whether you could maintain the SATs.
but it tells
But I
you on the
think
picture format,
capnography
Nick.
is an integral part of that, and I think this should be standard on charts. We need ways to document, a standardized way to document the outcome part of it. It's fine to write, I use two hands, I use an oropharyngeal, but what happened? And I think this is a great way to sort of standardize, to qualify the grading of the capnography trace.
I guess people just might bail out by the time, they've got this, especially in theatre where you've actually got your end tidal CO2. They'll try a couple of times and go, after pre-oxygenation, I'm not getting much of a CO2 trace, and then just go for their LMA or ET tube. So I guess, some of it's got to be the timing associated with this as well. Like, how long have they tried to face mask ventilate?
Nick, do you have a copy of the Airway alert that we're trying to standardize through?
I haven't got that scanned in, no.
Okay, so anytime there's a problem which has caused you, let's say, intubation problem or whatever, the difficult airway alert that the Queensland SwapNet group has sort of been adopted by Victoria and other places, it actually has this component as a part to fill in, and anyone you're having difficulty with should actually get an alert with them. And certainly in an Australian context, I'm just going to blow a bit of a trumpet here, in sense that as call to arms, is we should be getting this in My Health Record, and they've certainly done all the work to get the right computer size language, so when you tick it, it's ready to go in there. So I think that this is also should be integral to standardization, very much like video laryngoscopy scoring.
But it needs to be in more than the airway alert, because the airway alert is really for, I've got a problem that I need to pass on.
No, I'm saying
you go back and looking at old notes just on the anaesthetic chart, you want to know, you have some concern about intubation, and you just, but could they face mask ventilate them? They might not have intubated them previously, but it's nice to know.
I agree 100%. I think it should be a standard.
Yeah.
But quite often so medical legal hat on when I'm reviewing things, the information's sadly lacking.
Yep. I think one of the problems is with all these things, and that's the Concord scale, that, as you said, by Lim and Nielsen, I think their original article's in the BJA. I think it's just a letter, the original article. This is the Hahn scale, is another one. I have real issues with this, because I think if you look at the grade 1 and 2 is sort of all about the effort you put in, and then grade 3 and 4 are all about the outcome. There's a muddling of effort and outcome. And I think one of the problems, particularly in anesthesia, is often people they haven't put in much effort. They do sort of lazy one-handed thing. They get little triangular blips of CO2 and they say, oh, that's fine. And then they just document it as easy, but they don't know whether they could do better than that. They're just making a judgment. So that's why I think it's really important that you don't just document the outcome, but you document what you did. And I think rather than writing easy, if you were writing in those lazy cases, one-handed, no adjuncts, but I was getting a Concord grade C, you might have been happy with that, but at least it lets them know that that's what you were getting, rather than just, I thought it was easy, which is very, very subjective.
Nick, just before we wrap up, can I just answer one of the comments?
Yep, let me just put it up for you. Hang on.
It's Mauricio's things about strategies. The answer to that is, we talked about the hand grip. So when I'm doing one-handed grip, with the way my mask's on my hand, is I can rotate my hand back, sort of backwards, forwards, to try and optimize the seal, and then getting the tactile feedback. I sort of have an understanding of what my issue is, whether it's a leak or not. And then if it's, depending on what I'm experiencing, I then individualize it to either using an oropharyngeal and admitting defeat to my inability. So it comes back to the feel of the bag to actually optimize it, correct maneuver is.
And it's worth trying, these things out, moving your hands when you've got a straightforward case, which you're not concerned about in terms of airway management. It's worth, trying moving your hand around slightly, seeing how that affects the seal, see how that feels when you squeeze the bag, because you're learning then about, what might happen when it comes to the actual difficulty.
So there's just interesting Mapleson circuit being used in a pre-hospital environment, which doesn't, pre-hospital doesn't preclude it as long as you can carry two devices. You need the self-inflating bag if the oxygen fails, but if you can carry two devices, there's no reason you can't still use that first line. Okay, I'm gonna wrap up now. Thanks to both of you. That's been a fantastic discussion. Let me go back to this. Actually, let me go back to this screen because I think I have to.
Thank people.
I have to do something. I can't remember what it was.
References.
No, yeah, I do. Hang on, I've just got to look at the list of things I need to say here. I've lost my mouse. Hang on.
I can give you a heads up.
No, I'm good now. I found the list. Anyway, thanks to both Joe and Pierre. I'd like to thank Fisher and Paykel, our sponsors for the show. As Joe mentioned, then the resources, some of the resources are in the show notes already. The link to Pierre's article, and also to that vortex optimization strategies. There's a few other things we've talked about that I'll try and put in the show notes there, and we'll put them eventually on the Safe Airway Society on the Airwaves page. So
can I see the ANSCA assessment one as well, please, Nick?
The ANSCA assessment. Well, send me an email of what you want to go up, and you too, Joe. If there's anything else you want that we've talked about that you want to go up there, we'll put it up so that people can have access to it. Just again, I want to promote our workshops. Hang on, I think I've got to go to a different screen. Where am I? So the Perth workshop at Fiona Stanley on September the 9th, the New Zealand workshop in Auckland on October the 14th, and the big one-day meeting, SAS 2023 in Sydney at Royal North Shore Hospital on the 28th of October. Join the Safe Airway Society. It's well worthwhile. Continue this discussion on Twitter with the hashtag Airwaves Live, and you can tag the panel members in there if you want to get their input on anything further that we've discussed today. And I think that's all the other comments. The thank you. So I will just say thank you to everyone, to the audience for watching us, and thanks to both of you for being here.
Thanks for having me.
Okay, beautiful. Thanks, Joe. Thanks, Pierre. Cheers.
Cheers.